Nonprofits rarely have the time or money to really, really empirically study what they do. You have anecdotal evidence, you have what feels good, but this allows us to really take a research-driven look at what we're doing and why we're doing it, and help us to improve that. I'm Billy Kirkpatrick. I run Five Horizons Health Services in Tuscaloosa. We are formerly West Alabama AIDS Outreach.
We work with people living with HIV who are marginally housed or marginally homeless, evaluating the impact of housing factors on HIV outcomes.
One of the things we are doing is to analyze whether there are differences of people who receive case management versus those who do not receive case management.
And so there's a federally qualified health center called Watley Health Services in West Tuscaloosa, and they serve about 300 individuals with HIV/AIDS. They provide medical care related to HIV. Our agency, Five Horizons, provides everything else, which would be case management, including transportation, housing, financial assistance, food bank, all those things. But there are about 100 more people that utilize the medical care that opt out of case management, and we want to know the differences.
The second part of it is we're very interested in civic engagement. So how does a statewide HIV advocacy program help people living with HIV to increase their self-efficacy, and how it also helps potentially affect decision-making of policymakers.
The truth is, once someone is infected with something like HIV and AIDS, it almost leaves a mark in them.
Housing quality, housing stability really does impact priorities of people's lives. So people who don't have their housing needs met are not going to be thinking about health care. They're not going to be thinking about medications. And if they're not thinking about that, then that also has broader public health impact.
And mainly now that we are in the rural South, where Christianity is a big thing, and even if you talk about all the things that leads to HIV and AIDS, is that stigma of sexuality that is attached to it. And so when someone gets infected, they have to deal with all those, the stigma of being in this society with this disease.
We teach our clients to advocate on their own behalves, because it is their story that's powerful anyway. It's not my story. What's powerful is one of our clients standing in front of a legislator saying, when you vote on this, this pays for the medications that saved my life.
Will be where people living with HIV and AIDS are actually embraced into the community, where the idea of stigmatization is removed.
Could help them provide more systematic ways to actually gather evidence and analyze data to really see to what degree case management is having an impact.
Making sure that we are collaboratively addressing the needs. So it's not your population of clients and our populations, it's our population. If there are folks that won't utilize your service, then refer them to us, and vice versa. We want to work together on that and make sure that no one gets lost to care. We want to see a much larger scope of client leadership at the state so that they can take advocacy and lobbying messages not just to the local folks, but to the state folks and the national folks.
Community, what it means to work with a community partner and researcher, and creating that sustainable partnership.
So instead of researchers coming up with ideas that they want to implement and then using the community just as a means for recruitment, the IRL program really empowers community leaders to really help come up with a research question, make it a project that would have the most impact in the community by that project coming from within the community.
If I'm going to spend my career doing research, all that I care about is community-based research. It's why I brag on my partners all the time. There are universities that care about publications and publications, and that's well and good, I guess. But I really long for the day when researchers like my partners are given full credit for developing cutting-edge programs that change people's lives. I want that to be considered more weighty than getting something published in a journal that 6 people read. All right. Intercultural health. There is a dialogue, an open, consistent, respectful dialogue between opposing points of view.
In a culture of health, people living with HIV and people who are impoverished, or people who live in rural counties, or people who are minorities, whether sexual minorities or race or gender minorities, receive the services that they need and also have a voice.
In a culture of health, everyone has an equal opportunity to access whatever they need in that society.